Hi, hi, very good morning. I am Dr. Janak Patel, MD, General Physician. All my video lectures are mainly for educative purpose. In continuity with the previous series, today we'll be talking on the one of the another aspect of potassium imbalance, that is hypokalemia. So hypokalemia is a potassium level less than 3.5 milliequivalent in blood, and it will have effect on cardiac muscle, skeletal muscle as well as smooth muscle. We'll be discussing under these headings, that is definition, etiology, pathophysiology, clinical features, investigations, differential diagnosis, treatment part. So hypokalemia refers to decrease in plasma potassium, or we call blood potassium level below 3.5. Mild is between 3 to 3.5. By and large, those are asymptomatic. Less than 3 is usually symptomatic and we call that as a moderate. And less than 2.5 we call that as a severe. And less than 2 milliequivalent, it is very severe. Hypokalemia can be seen in any individual, and severity will depend upon clinical manifestation, will depend upon the severity of hypokalemia and how rapidly it develops. We already mentioned between 3 to 3.5 is mild variety, usually they are asymptomatic. Moderate is between 2.5 to 3, that is symptomatic groups, and less than 2.5 severe, and less than 2 is very severe. Depending upon the etiology, spurious, or we call factitious or pseudo hypokalemia, maybe because of poor intake of potassium due to redistribution and extra renal losses and renal losses. Now we'll be going through little regarding a pathophysiology side. Hypokalemia will be because of one, decreased intake of potassium, which is rather very uncommon, but still if the person has got decreased intake, likely to produce hypokalemia. And the major cause or major pathophysiology will be because of renal loss or because of non-renal losses. And then comes cellular shift, where potassium is shifted inside the cell, so extracellular potassium becomes less. That will be the another very common mechanism which will be producing hypokalemia. Because of hypokalemia, you will have an effect on skeletal muscle, cardiac muscle and smooth muscle. And this is because of the change in the electrical potential across the membrane due to alteration in the potassium balance, intracellular as well as extracellular potassium. Hypokalemia will also have an effect on kidney because of impaired concentrating ability, polyuria polydipsia, which is very commonly seen in nephrogenic diabetes insipidus. Impaired ammonia production, like in case of hepatic failure, it can worsen. Impaired urinary acidification. Renal insufficiency will reduce GFR as well as renal blood flow can be there, which will produce then chloride wasting, metabolic alkalosis, renal cyst formation, tubular vacuolization, interstitial nephritis, etc. can be seen in a person with hypokalemia. We already mentioned that whatever, if we understand this, it is very simple. We take around say 100 milliequivalent of potassium in a diet, the chances of hypokalemia will be minimum. All those potassium will be fully absorbed, of which 90 milliequivalent will be thrown out in urine and 10 milliequivalent will be thrown out in fecal matter. And we say roughly 1% will be thrown out in sweat. So there will be some amount of extracellular potassium which is being present that can lead to intracellular shift due to insulin beta 2 adrenergic stimulation, or we call agonist, and metabolic alkalosis. This will be the common conditions, and that will result into hypokalemia as well as in kidney. Potassium level can be altered because of excessive excretion of potassium, and that excessive excretion of potassium can occur because of diuretics, potassium losing nephropathy, then aldosterone imbalance, where aldosterone will produce reabsorption of sodium and loss of potassium. So primary hyperaldosteronism as well as secondary hyperaldosteronism, or person who is on a large dose of loop diuretics, where you will have a hyponatremia with hypokalemia, etc. So those conditions will produce loss of potassium. Very, very rarely you can lose potassium by GI tract, not very common, but can be there. We'll be talking about that. And excessive sweating can also lose some amount of potassium. So at the level of distal convoluted tubule and collecting system, aldosterone is one where you will be losing potassium in exchange for sodium, and in the convoluted tubule H ions will be exchanged for potassium. So if a person has got alkalosis, potassium is lost for preservation of H ions. So this will be the mechanism which will be playing a role in case of loss of potassium. GI tract loss can be there if any person who develops a diarrhea. We have already mentioned regarding a renal losses. Because of excessive renal loss, potassium, if it is lost, person can develop. And in that particular condition, you will have a urinary potassium more than 20 milliequivalent. Will search for renal causes, and if the urinary potassium is less than 15, or we say less than 20, we search for other causes like GI tract or because of sweating, etc. And then we also search for other causes like cellular shift, which can be there because of insulin, catecholamines, metabolic alkalosis, excessive glucose, etc. This will be internal redistribution or intracellular redistribution. And we are aware of that there will be effect on sodium potassium pump because of insulin, aldosterone, as well as beta adrenergic catecholamines that can have effect on sodium potassium pump. So do keep it in mind. There are some congenital syndromes which is affecting the distal convoluted tubule like Gentleman syndrome, Bartter syndromes, Liddle syndromes, where you can have a loss of potassium. So these conditions will be congenital condition and they are related to kidney. So potassium excretion will be increased by aldosterone, high sodium delivery to the collecting ducts like in the loop diuretics, osmotic diuretics, and also if the person has got a high serum potassium level, as well as if negatively charged ions like bicarbonates, then also potassium will be lost. Example, metabolic alkalosis. So as far as hypokalemia is concerned, poor intake, increased urinary loss, increased GI tract loss, and increased transcutaneous loss like in sweating, and transmembrane shift intracellular will produce hypokalemia. This will be the mechanism which will be producing hypokalemia in a person. These are all the different hormones which are playing a role as far as. So alkalosis will produce potassium shift intracellular and H ions will be preserved. So potassium is shifted, magnesium will be also shifted in case of alkalosis, while in acidosis H ion will shift intracellular and you will have a shift of potassium outside and magnesium will be shifted outside. So there is also a nice relation between hypokalemia and hypomagnesemia. This will be seen very nicely in case of a Bartter types 1 and Bartter types 2, where you have got shift of magnesium and potassium. So in this particular condition, potassium is shifted inside the cell for 3 molecules of sodium at sodium potassium pump, and because of Bartter's type 4 you will have magnesium, calcium, potassium and ammonia exchange which will be taking place from tubular lumen into blood, while in Bartter's type 1 and 2 you will have potassium exchange for sodium chloride. So sodium and chloride will move inside and potassium will be thrown out, producing hypokalemia. So this will be the mechanism for hypokalemia in potassium losing nephropathy. So etiology we can divide into spurious, which is pseudo hypokalemia, poor intake of potassium, very commonly in starvation or person who is having abnormal eating habits of clay, we call pica. Redistribution because of movement of potassium inside the cell. Extrarenal losses usually associated with preservation of renal potassium, and renal losses often associated with acid-base disturbances, particularly metabolic alkalosis. So decrease intake, redistribution, renal loss and extrarenal loss. This will be the common causes. So pseudo hypokalemia will be because of extracellular potassium when stored at a room temperature shifts into intracellular compartment. Apparent hypokalemia can occur because of artifacts in storage And rapid separation of a plasma storing at 4 degrees centigrade confirms the diagnosis and avoids these artifacts in an inappropriate treatment. So proper storing should be done to reduce the chance of pseudo hypokalemia. So if preservation is not proper, storage is not proper, it can reduce potassium in blood, that is in serum, and that will be shifted into cellular compartment. That is called spurious or pseudo. Due to reduced intake, very rarely seen in anorexia, bulimia, starvation, pica, and chronic alcoholism. Also sometimes because of dental problem, person is not able to chew properly and swallow properly. That can also result into potassium deficiency. And poor quality and quantity of food, particularly person who are very much prone to take tea and toast diet in elderly individual, because that is deficient in potassium. If person is hospitalized and he is on TPN, which is poor potassium TPN, or he is on a IV treatment where potassium replacement is poor, or person who is having a major GI tract surgery and he is a nil by mouth, or person who develops a severe malnutrition like Kwashiorkor, can develop potassium deficiency. As far as GI loss is concerned, persistent vomiting, nasogastric drainage, diarrhea, laxative abuse, and if the person has undergone ureterosigmoidostomy, and that can lose good amount of potassium. And once in a while, extra renal losses can be because of excessive sweating. As far as urinary loss is concerned, the most common cause is diuretic. Those are loop diuretic, particularly furosemide more common than torsemide. If person has got a excessive mineralocorticoid, or person who is taking excess of mineralocorticoids like fluorocortisone, or person has got a renal tubular acidosis of variety type 1, type 2, more common but not seen in type 4 variety of Bartter syndrome, that is called renal tubular acidosis. There are some other variety of nephropathy we call the salt wasting nephropathy like Gitelman syndrome, etc. Some drugs like amphotericin B can also produce excessive urinary potassium loss, polyuria. Even hypomagnesemia can also produce potassium loss in urine. This will be good number of conditions which can produce renal losses. As far as redistribution is concerned, where potassium will be shifted inside because of insulin drip, particularly when it is given to a type 2 diabetes mellitus, catecholamines, metabolic alkalosis. If person has got severe cell proliferation and person develops excessive leukocytes or excessive thrombocytes. Also, it is seen in a hypokalemic periodic paralysis when they take excessive carbohydrate diet. So even excess of glucose will produce stimulation of insulin, and that insulin will now shift intracellular. So even high glucose can also produce shift of potassium, not directly but because of increase in insulin, and insulin will produce intracellular shift. So as far as the renal causes is concerned, very frequently with this good number of condition, person will have hypertension like hyperaldosteronism, classical example Conn syndrome, and secondary hyperaldosteronism because of renal ischemia. Also, if the person has got mineralocorticoid activity because of excessive intake of mineralocorticoids. Also, it can be seen in a Cushing syndrome, ectopic ACTH, or person who is on a glucocorticoid therapy. apparent mineralocorticoid excess, and also if the person is in diet, licorice is high or carbenoxolone is also elevated. There is one more syndrome where you lose lot of potassium is called Liddle syndrome. So you can have that, and they are associated with hypertension. The classical example is hyperaldosteronism, maybe primary or maybe secondary. But the condition where blood pressure is normal or low and person has got renal losses, it is very commonly seen with alkalosis, and this particular is seen very commonly if the person is on a loop diuretics like furosemide or on a large doses of thiazides. And also it is seen very frequently in a person with Bartter syndrome or Gitelman syndrome. With acidosis, it will be seen in type 1 and type 2 variety of renal tubular acidosis. And if the person is on a carbonic anhydrase inhibitor also, you will have acidosis with hypotension or normal blood pressure. With variable pH, particularly in a post-obstructive diuresis, if person has undergone removal of obstruction and then he develops a diuresis, in that condition person pH may be variable, may have alkalosis or acidosis depending upon the conditions. And recovery after acute tubular necrosis or in a person with magnesium depletion, that is hypomagnesemia. These are good number of conditions which will produce renal losses. While GI tract losses, in vomiting person will have alkalosis, and nasogastric aspiration also person will have alkalosis because they lose lot amount of H ions and chloride. While with diarrhea, laxative abuse, then tumors of rectum like adenoma, villus adenoma, fistula, bowel obstruction, ureterosigmoidostomy, person will develop acidosis because they lose potassium along with bicarbonates. So in diarrhea they will have acidosis, while in vomiting they will have alkalosis. So this should be kept in mind. So in potassium losses, person can have hypertension or hypotension, and person can present with alkalosis or acidosis, maybe renal or maybe GI tract losses, and that helps to pinpoint whether it is a GI tract disorders or renal disorders and which type of disorders. It will be very helpful. So as far as the urinary loss is concerned, in summary, it can be hyperaldosteronism, Cushing syndrome, Fanconi syndromes, and renal tubular acidosis type 1 and type 2. If there is an ectopic production of ACTH will result into Cushing syndrome, and person can have loss of potassium. And because of loss of potassium, person can develop hypokalemia. Thiazide diuretics particularly will enhance the sodium and potassium exchange and potassium excretion. So sodium will be exchanged for potassium loss. That will be very commonly seen in person with a thiazide diuretics in excess. There are some compounds which will increase the action of aldosterone and can produce potassium loss. Licorice and tobacco can also increase the aldosterone-like action. Bartter syndromes increases the secretion of renin and increases the aldosterone, and that can produce again potassium loss and sodium preservation. So sodium exchange for potassium loss, sodium and potassium exchanges. So indirectly in a renal loss you can develop metabolic alkalosis, metabolic acidosis, and without acid-base imbalance. Metabolic alkalosis will be very common in Cushing syndromes, renovascular hypertension, and monogenic hypertension, while Bartter syndrome, Gitelman's, and diuretic will be normotensive, while metabolic acidosis will be very common in case of a renal tubular acidosis, diabetic ketoacidosis, and ureterosigmoidostomy, where person is losing good amount of bicarbonate, so relatively person will now develop metabolic acidosis. While in case of interstitial nephritis and hypomagnesemia, there will be no disturbances as far as acid-base balance is concerned. Redistribution will be very frequently because of high glucose. You will have excessive insulin production, and that can shift potassium intracellular, producing hypokalemia, beta 2 agonist, thyroid hormones excess, and refeeding syndrome, and even sodium chloride IV can produce little amount of hypokalemia. Also, hypokalemic periodic paralysis can also result. Thyrotoxicosis we have already mentioned, and also in case of a metabolic alkalosis, you can develop hypokalemia. Transcellular can be affected by certain drugs like epinephrine, salbutamol, pseudoephedrine, theophylline, verapamil, chloroquine, insulin overdose, etc. There will be transcellular shift. Renal potassium loss can be exaggerated by azithromycin, thiazide, loop diuretics, fludrocortisone, penicillin, aminoglycoside, amphotericin B, cisplatin, which is utilized as an anti-cancer drug, etc. And you can have a loss of potassium in a stool with phenolphthalein, certain resins, sulfonate, etc. Acid-base disorders which can end up with hypokalemia. So in a diabetic ketoacidosis, renal tubular acidosis, GI losses in the form of diarrhea, laxative abuse, also because of a ureterosigmoidostomy, you can develop a metabolic acidosis, and also in a salt wasting nephropathy. But you will develop a metabolic alkalosis in diuretic therapy, vomiting, nasogastric aspiration, mineralocorticoid excess, penicillin derivative, nephropathy, Liddle's, Barter's, or Gitelman syndrome will develop metabolic alkalosis, because here you got loss of H ions along with this treatment, and that's the reason why they also develop metabolic alkalosis. In vomiting and nasogastric aspiration, you lose H ions, and here the H ions will be lost in renal. So metabolic alkalosis will be associated with furosemide, particularly diuretic, vomiting, nasogastric aspiration, mineralocorticoid excess, penicillin derivatives, Liddle's, Barter's, and Gitelman syndrome. They will develop metabolic alkalosis because of loss of certain materials. Here in vomiting and nasogastric aspiration, you will lose H ions, and also in this there will be loss of potassium as well as H ions. Certain hyperaldosteronism which can be primary or secondary. Secondary is very common in malignant hypertension, renal artery stenosis, renin secreting tumors, Cushing syndromes, and very frequently you see excess of aldosterone secondary due to Bartter syndrome, Liddle's, and Gitelman's syndromes. While primary will be very common in case of congenital adrenal hyperplasia, aldosterone producing adenomas, hyperplasia, adrenal hyperplasia, and maybe idiopathic. So do keep this thing in mind. So primary hyperaldosteronism, secondary hyperaldosteronism. In secondary, usually we have got renin high, aldosterone high. While in primary, we have got aldosterone high, renin is normal or low. And in pseudo, we'll have both low or both normal. And all forms of mineralocorticoid excess are associated with hypertension. So if there is a mineralocorticoid excess, whether it is primary or secondary, you will have hypertension. So whenever you want to approach to any person with a hypokalemia, we want to find out, is it spurious or it is redistribution. So first we always look at potassium level. If potassium level is low, we confirm the diagnosis of hypokalemia. We first rule out the spurious cause, and then we look at the urinary potassium. If urinary potassium is less than 20, it is extra-renal causes. If urinary potassium is high, it is an renal causes. Say in a renal causes, now we look at the pH. If person is having acidosis, it is metabolic acidosis. In that, we try to rule out a cause like renal tubular acidosis, person on acetazolamide, diabetic ketoacidosis, and ureterosigmoidostomy. If person has got pH which is high, then we try to look for metabolic alkalosis group. We'll be looking in second slide. And if there is excessive urinary loss, but there is no abnormality as far as pH is concerned, pH is between 7.35 to 7.45. We look at these groups like magnesium deficiency, renal wasting syndromes, penicillin, aminoglycosides, leukemia, etc. And if there is an extra renal cause, if it is metabolic acidosis, we look at the diarrhea, fistula, rectal tumors like villus adenomas, ureterosigmoidostomy, those groups. So that will end up with what we call as metabolic acidosis. But if there is a normal acid-base balance, then we look at, by and large, say suppose more of alkalosis, then we look at nausea, vomiting, anorexia, decrease intake of potassium, then excessive perspiration, laxative abuse. Laxative abuse will come here in metabolic acidosis. So this will be some of the conditions. And if there is a metabolic alkalosis with urinary excessive loss, you look at the urinary chloride. If urinary chloride level is high and person is hypertensive, you look for aldosterone level, mineralocorticoid, and then we look at the renin level. High renin, high aldosterone, look for malignant hypertension, renin secreting tumor, renovascular hypertension. Low renin, high aldosterone, primary hyperaldosteronism like Congenital syndromes, secondary due to adenoma or adrenal hyperplasia. If there is a low aldosterone, look for these conditions like Liddle syndromes, exogenous mineralocorticoids, apparent mineralocorticoid excess, then carbenoxolone, etc. If person is normotensive, then look diuretics, Bartter syndromes, Titelman syndromes, look for those. If person has got normal aldosterone level and he is hypertensive and he has got urinary chloride high, then look for Cushing syndrome because there is normal renin, normal aldosterone, look for Cushing syndrome. And if the urinary chloride is low and person is normotensive, vomiting, nasogastric drainage, diuretic use, post hypercapnia, and chloride losing diarrhea, this will be the conditions. Complicated, but you will have to use these algorithms when you are approaching. So you can divide into high renin, high aldosterone groups, low renin, high aldosterone group, low renin and low aldosterone group. We have already mentioned before. You can go through at your leisure time. So mineralocorticoid hypertension, this will be the conditions and what test you do. Say in Lidl's, you do amiloride test. In gentlemen's, you look for a hydrocortisones level, mineralocorticoid mutations, spironolactone test. Aldosterone producing tumor, you look for the renin aldosterone ratio, or you can go for MRI. Secondary hyperaldosteronism, you look for the renin to mineralocorticoid activity, etc. So these are where mineralocorticoid is excess and you have got hypertension. We already mentioned regarding urinary chloride level previously. Here it is more than 20, less than 20. In the previous one it was 10. These are decreased potassium intake causes, major causes. We already mentioned, so I am skipping this slide. Now, once a person develops hypokalemia, so if potassium level is less than 3.5, good number of time person is asymptomatic. But depending upon the acuteness, person can develop symptom signs even with slight reduction in potassium from 3 to 3.5 to 3. And first effect will be on a skeletal muscle, smooth muscle, and on cardiovascular system. Depending upon the severity of potassium loss. So if potassium is less than 3.5 up to 3, usually they are asymptomatic. Between 3 to 2.5, they will be symptomatic. And if it is less than 2.5, person usually will develop severe symptoms, and very severe if the potassium is less than 2. So in skeletal muscle, weakness, cramps, person can have tetanic spasms, person can develop severe weakness, so almost paralysis like paralytic ileus, and person can also develop destruction of the muscle, rhabdomyolysis, and with rhabdomyolysis, myoglobinuria, and can damage kidney. As far as smooth muscle is concerned, because of decrease in peristalsis, constipation, paralytic ileus, and bladder can also have decrease in smooth muscle contraction, so urinary retention, that will be in smooth muscle. As far as Ecg changes is concerned, because of hypokalemia, you will have a changes in Ecg and person can develop atrial arrhythmias like atrial flutter fibrillation, ventricular arrhythmias, and person if he is on digoxin can develop digoxin toxicity, and digoxin excess can also produce hypokalemia. As far as Ecg changes is concerned, person will develop ST depression, decreased T wave amplitude, P wave amplitude will be tall and broad, you will have little prolongation of PR interval and appearance of U wave. This will be very peculiar as far as Ecg is concerned. So patient between 3 to 3.5, usually they are asymptomatic. Once they develop a symptoms, muscular symptoms are weakness, mainly affecting lower limb as compared to arms, cramps, ileus, rhabdomyolysis, and person will start developing atrial fibrillation, ventricular tachycardia, ventricular fibrillations. You can remember whichever way you want. Person will develop alkalosis, respiration will be shallow, person will be irritable, confusion, drowsiness, weakness, fatigue, tachycardia. Late stage, person will start developing bradycardia. Among tachycardia, atrial flutter fibrillation, ventricular tachycardia, ventricular fibrillation, lethargy, thready pulse, decreased motility, paralytic ileus, nausea, vomiting, etc. Another way to remember a sick vault, alkalosis, shallow respiration, irritability, confusion, drowsiness, weakness, fatigue, arrhythmia, lethargy, and thready pulse. Whichever way you want to remember. So, commonest fatigue, myalgia, muscular weakness, flaccid paralysis, or reflexia. As potassium approaches less than 2.5, person will have a even lower extremity with trunk and upper extremity also getting involved. And when it is much more lower, person will develop rhabdomyolysis and myoglobinuria, which can produce damage to kidney. Decreased potassium release due to profound hypokalemia can reduce blood flow to muscles during exercise, leading to ischemic rhabdomyolysis. And following a rhabdomyolysis, potassium is moved outside that can produce false normal potassium level. Because of involvement of the smooth muscle, paralytic ileus, constipation, and urinary retention. This will be very common. If you have got a drop of 0.3 milliequivalent of potassium, you will have loss of 100 milliequivalent in total potassium deficit, total body potassium deficit. So that helps you in calculations. Among cardiovascular complications, weak thready pulse, irregular, that is arrhythmias, heart blocks, hypertension. Among Ecg changes, ST depression, T wave inversion, prominent U wave. Usually we interpret as a QT prolongation, but it is QU prolongation. So you can see that the ST depression, T wave will become flat, then T wave will be inverted. You will have a two humps, T and U. U will be prominent than T wave, and later on the T wave almost disappears, so you have got a QU interval. Respiration because of involvement of the respiratory muscles, shallow respiration, dyspnea, GI tract, smooth muscles are involved that will produce decreased peristalsis, abdominal distension, paralytic ileus, nausea, vomiting, constipation. In CNS, anxiety, confusion, lethargy, and person can even be comatose. As far as neuromuscular junction is concerned, decreased tendon reflexes, muscle weakness, leg cramps, and even person can develop rhabdomyolysis. So that will be different symptoms. You can see ST becoming flat, then slowly the ST depression, T wave almost becomes inverted, U wave appearance. So U wave will appearance, biphasic T wave, then T wave will be inverted, ST depression will be there, P wave will be prominent, there will be little prolongation of the PR interval. So slight PR interval prolongation, little peak P wave, ST depression, T wave will be almost getting inverted, depressed T wave or may even get inverted, and you will have a prominent U wave. And when there is a T wave which is present with U wave, it is a two peak. So flattening of T wave and T wave inversion is the early sign. Then QT interval prolongation, U wave appearance, ST depression. Now person starts getting ventricular arrhythmias like extrasystolic tachycardia, atrial flutter fibrillation, and when it is very severe means if the potassium is less than 2 milliequivalent, torsada pointis and person can go into ventricular fibrillation. So ST depression, flat T wave, tall U wave. Then further prolongation of PR interval, U wave size will increase, and when it becomes less than 2, wide and bizarre QRS complex, marked ST depression, inverted T wave, and prominent U wave. So QRS complex widening will also suggest the potassium is becoming very low. We call very severe hypokalemia. So you can see here that because of this you have got tall P wave. P wave is tall. And here you can see T and U wave. U wave is more taller than T wave. And this will be seen in chestlets, that is V3, V4, V5. Better seen in this chestlets. V2, V3, V4, V5, even in V6. So it is better seen in a chestlets, and you will have a prominent P wave which will be seen in a limblets. So even sometimes with 1.4 also you can see that T wave is still seen. Such disturbances can be there. Also this can be exaggerating your VT and torsada pointis, where hypokalemia will be combined with some of the drugs like digoxin toxicity, some drugs which prolongs the QT interval, hypomagnesemia, and even in case of a coronary ischemia that can worsen complications of hypokalemia. As far as investigation is concerned, in step 1 we get a good history, try to rule out extra renal causes of loss of potassium like diarrhea, vomiting, diuretics, etc. Step 2, look for magnesium, because good number of time hypomagnesemia is associated with hypokalemia. Then we look at the serum potassium, we look at the pH, and we look at the urinary potassium, urinary chloride, and urinary pH. That will help to differentiate renal different parameters. And ABG to find out acidosis or alkalosis, whether it is metabolic or respiratory. But in case of metabolic alkalosis and acidosis, potassium balance will be disturbed. So that will be very helpful. And don't forget Ecg examination. So serum potassium, ABG, Ecg, and urine examination for potassium, chloride, and pH should be done. So do look for those conditions. So urinary potassium, where there is a high, it is renal loss. If it is less, it is GI tract loss. Usually the figure which is being kept is 20. Here it is urinary potassium to creatinine. So we try to rule out, so if there is a high urinary loss and if there is a metabolic acidosis, always look for renal tubular acidosis type 1 and type 2 and diabetic ketoacidosis. And if there is a alkalosis, look for mineralocorticoid excess and salt wasting nephropathy. But if urinary potassium is less and person has got acidosis, always look for lower GI tract causes like diarrhea, laxative abuse, also ureterosigmoidostomy, and if there is a metabolic alkalosis like vomiting, laxative abuse. Some of the laxative abuse can produce even metabolic alkalosis. So urinary pH, urinary potassium, urinary osmolality gap, etc. will be helpful to evaluate, even chloride. Then comes ECG, we have already mentioned everything by and large. So you will have, in a severe variety, you will have a tall P wave, little prolongation of the PR interval, ST segment depression, T wave inversion, and tall U wave. And there will be QU interval will be markedly prolonged. As far as management is concerned, hypokalemia, 1. Decrease the potassium loss, replenish the potassium by either oral or by IV, evaluate the potential toxicity what has happened, and determine the cause in order to prevent the future episodes. To reduce the potassium loss, discontinue the diuretic therapy, laxatives, etc. Use, if at all, if you want to continue with the diuretic, you use the potassium sparing diuretics like spironolactone or amiloride. Because if the person has got a heart failure, you have to give diuretics, so combined with spironolactone. Treat diarrhea or vomiting, whatever is the cause of potassium loss. While supplementing potassium, the most common route should be, if person is able to take orally, always oral is more beneficial. IV potassium chloride is given only if the person is having Ecg changes, life-threatening cardiac arrhythmias, then potassium chloride is given IV. But when you are giving IV by peripheral lines, you should not give more than 10 milliequivalent per hour and not more than 20. And you can give as much as 40 milliequivalent per hour via central lines. So whenever you want to give a large dose, it has to be given by central line only. By and large, amiloride and spironolactone will be very useful in a person with hyperaldosteronism. And try to identify the basic etiology, and if it is treatable, treat the basic etiology. Urgent replenishment of potassium is required if the rate of hypokalemia is developing very fast, or if the person is at a very high risk because of QT prolongation, there is an active ischemia, then person should be treated with potassium replacement and mainly by IV. Treatment should involve both addressing the underlying etiology as well as replacement of potassium. Outside the high risk comorbidities or active arrhythmias, there is no need to replace to suprarenal level, supranormal level. So don't bring it above 4. So intervention which are required for treatment of hypokalemia is, you need to determine the cause and treat the underlying cause. You must have a good IVSS, particularly intravenous line, maybe central line, so you can give adequate dose, because there is a restriction in a peripheral IV lines. Increase potassium intake orally if a person can take, or correct with the IV fluids. Never give potassium by IV push, because it can give rise to cardiac arrhythmias. We already told you between 2.5 to 3.5 we call it as a mild to moderate. Less than 2.5 it is a low potassium level, and when it is less than 2 it is dangerous one, and that has to be treated by IV only by and large. But this can be treated by oral, and here we try to find out the cause, treat the cause, and if the person is symptomatic and there is a chance of a dangerous cardiac arrhythmia, should be treated by IV or otherwise by oral. Prevention of hypokalemia, daily intake should be good. Prophylactic potassium supplement should be done. Already the person who is on digitalis, long-term diuretics, or large dose of steroid, because they are likely to develop hypokalemia. And prevention of hypokalemia is required in a person who are on digitalis therapy, liver failure, previous MI, ischemic heart disease, diabetes mellitus, you should take adequate quantity of potassium orally. Also, person who are on TPN therapy post-operative should be given potassium, and there should be potassium in an IV fluid if a person is on a long-term IV therapy. So you should replenish at least minimum 40 to 50 milliequivalent of potassium every day by either IV or oral. Also, if the person has got hypomagnesemia, along with potassium, magnesium should be replaced. Otherwise, person will develop resistance hypokalemia. And magnesium deficiency is suspected if person is having malnutrition, chronic alcoholic, diarrhea, who is on diuretics, particularly loop diuretics, and who is not responding to replacement of hypokalemia even with adequate doses, or person has got associated hypocalcemia, person with diabetes, or person who is on aminoglycosides since long time. Try to replace magnesium simultaneously. This is a very good one, algorithms, which is giving you a very good idea regarding how you find out the different conditions and how you approach. Almost we have discussed everything. So try to, this is a very good slide. Go through your at leisure time. It is giving you almost in detail completely regarding all the different mechanisms and all the different etiology, how you identify those conditions. Say roughly if I say, if person is having hypokalemia, you get a good history, good physical examination and basic laboratory parameters. Now in this, if we come across what we call hypokalemia, which is there, which is less than 3.5, it is an emergency, and move to the therapy and start treatment. If there is a pseudo hypokalemia, no further workup is required. If there is no pseudo hypokalemia and there is no emergency, then we go for urinary potassium. If there is a clear-cut evidence of low intake, if answer is yes, then you treat accordingly and reevaluate again. Means you replenish orally and reevaluate again. If there is a clear-cut evidence of a transcellular shift, either because of insulin excess or beta-adrenergic hyperthyroidism, barium intoxication, theophylline, chloroquine, etc. If answer is yes, treat accordingly. If answer is no, now we are going for what we call as a renal loss, non-renal loss. So first always we try to rule out decrease intake, intracellular shift and pseudo hypokalemia, and if there is an acute emergency. After ruling out all those, we look at the urinary potassium. If urinary potassium is more than 20 or less than 20, more than 20 renal loss, then we go for the renal conditions. If it is less than 20, we call for extra renal loss like metabolic acidosis, excessive sweating, and metabolic alkalosis, which can be due to diuretic overuse, vomiting, nasogastric drainage, and profuse sweating. This will be the condition we try to rule out and treat accordingly. If it is a renal loss, now we try to look at the blood pressure. If blood pressure is high, and look at the aldosterone level. So high aldosterone, hypertension with high urinary potassium, 3 combination. And if there is a high renin, so high renin, high aldosterone, hypertensive with urinary potassium loss. And if it is a high renin, then look for malignant hypertension, renal artery stenosis. If renin level is low, means low renin, high aldosterone, then look for, this is primary hyperaldosteronism. If aldosterone is low, renin, cortisol is high, then Cushing syndrome. If cortisol is normal and aldosterone is low, look for Liddle's, licorice, etc. And if there is normotensive, blood pressure is normal, then look for acid-base imbalance. Then we don't look for aldosterone or renin level. So look for the acid-base imbalance. If a person has got metabolic alkalosis and urinary chloride level is more, then look for loop diuretics, Bartter syndrome. If urinary chloride level is low, then Gitelman syndromes or Thiazide Diuretics. And if urinary chloride level is very low, then vomiting, chloride, diarrhea, etc. And if a person has got metabolic acidosis, then look for renal tubular acidosis, diabetic ketoacidosis, amphotericin, and acetazolamide. And if pH is not abnormal, then look for penicillin and non-reabsorbable anion groups. This is the way usually you can approach. So approach to hyperkalemia, first rule out redistribution or depletion like insulin therapy, beta agonist like excessive salbutamol, metabolic alkalosis, beta 2 adrenergic stimulation like acute myocardial infarction, megaloblastic anemia, barium poisoning, etc. Rule out those conditions. Redistribution and depletion. Depletion causes like GI losses, duct diuretics, amphotericin B, osmotic diuresis, refeeding syndromes, mineralocorticoid excess, renal tubular, we call salt wasting nephropathy or renal tubular acidosis, magnesium deficiency, etc. We always try to rule out that, depending upon which way you are approaching. Then you go to the second step, you have to estimate the deficit. So roughly 0.3 milliequivalent drop, person has lost 100 milliequivalent. So if there is a drop of say 1 milliequivalent of potassium in blood, then person has lost almost 300 milliequivalent of potassium in body. So that much has to be replaced. You have to calculate accordingly. Then now you have to choose the route. Nearly oral is the best way over IV. But if a person is having critical symptoms in the form of cardiac arrhythmias, you might have to give IV. Oral is less dangerous because it will reduce the chance of IV burns. So IV therapy is only in the patient who are nil by mouth and who has got severe depletion. So oral potassium is indicated in most of the patient. You can give 40 milliequivalent at a time and you can give 3 times or 4 times in a day. Major side effect will be only GI upset. But when you give IV, main indication if you cannot give orally or if there is an emergency. Via peripheral lines, you can replace only 10 milliequivalent per hour and you should not replace more than 20 milliequivalent. While with a central line, you can give as much as 40 milliequivalent per hour, but person will have a high chance of getting burning pain at the IV lines. So, for a patient with a hypokalemia in a setting of essential diuretics, particularly in a heart failure or hyperaldosteronism or potassium sparing diuretic will be more effective then chronic potassium replacement. So in this particular group, you should put them on aldosterone. Now you have to choose the potassium preparations. Among oral preparation, potassium chloride is the most commonly which is being utilized, and also in the form of solution, that is 15 ml will be equivalent to 20 milliequivalents. So you can give 15 ml or 30 ml, that is up to 40 milliequivalent 3 to 4 times in a day by oral preparations. Other way is a potassium rich foods like fruit juices, tender coconut water, banana. These are topmost on the list. You can use juicy fruits, dry fruits, chocolates, coffee, soup, and you can use potassium in a form of a salt substitutes. These are all the fruits which are rich in potassium. So you can use any one of these fruits or vegetables, or you can use this also, but best is fruits and vegetables. After choosing the potassium preparation, IV therapy will be utilized only in selective groups. Most commonly, pot chlor or potassium chloride is preferred for IV. Whenever you are giving IV, you have to be very careful because it can give rise to hyperkalemia. So always remember that. And 1 ml will be equal to 2 milliequivalent. So 10 ml of potassium, 15% potassium chloride will give rise to 20 milliequivalent. So this particular you have to keep it in mind. So always monitor whenever you are giving IV therapy, you have to monitor potassium and you have to monitor on ECG. Avoid IV potassium till urine output is established. So if a person who has got any renal damage, avoid giving IV potassium because it can result into sudden hyperkalemia. Never give IV because it can give rise to sudden hyperkalemia and person can die because of cardiac arrhythmias. If person has got acidosis, you can treat with soda bicarb. But when you are treating with soda bicarb, may aggravate the precipitation of hypokalemia due to intracellular shift. So when you are treating with soda bicarb, you must also watch for hypokalemia. So in a severe hypokalemia, potassium chloride should be mixed with isotonic saline. Do not use 5% dextrose as a dilution because dextrose will stimulate insulin release and that will shift intracellular potassium. So this should be avoided. So ideally you should combine with isotonic saline. Initially aggravates hypokalemia which is transient, but the dextrose will worsen hypokalemia further. So that particularly potassium should be monitored carefully, and if a person is having diabetic ketoacidosis, HON or hyperosmolar stage, then in that particular person also you should keep a watch for hypokalemia because in this particular because of excess of glucose will be stimulating insulin and that will be shifting potassium from extracellular compartment into intracellular compartment. You must keep a watch on this. So person will have a high chance of developing hypokalemia. 100 milliequivalent of potassium, that is 5 ampule of 15% is mixed with 1 liter of 0.9 saline, and infusion of this saline is given 100 ml per hour. And when you are giving 100 ml per hour, you are approximately giving 10 milliequivalent of potassium chloride per hour. An average rise of this will produce 0.25 milliequivalent when 20 milliequivalent of potassium is being given in 1 hour. So you will be elevating by 0.2. So, but still you will have to have a regular checkup by blood as well as by ECG. Whenever you give IV potassium, and if it is more than 40 milliequivalent per liter, then chances of severe phlebitis is very high. So it should be fused. You should do an IV infusion by central line, and always observe for sudden hyperkalemia, particularly in a person who has got a renal impairment. Do keep this thing in mind. Doses and timing should be properly chosen, because frequency of IV lines, IV fluids should be decided on how much the person is responsive. So that should be either it is a BID or TID dosing, whatever you are deciding should be on what is the ongoing loss, what is the present status, how much he has responded, what is the clinical symptoms and signs, etc. should be considered. So one thing is definitely there, avoid IV infusion rates faster than 20 milliequivalent per hour, because it can end up with cardiac arrhythmias. So this is a must. In a severe hypokalemia, diabetic ketoacidosis, you have to reassess frequently and look for hypokalemia. As far as follow-up is concerned, particularly it should be very aggressive in a person with a diabetic ketoacidosis, person who is on diuresis, acute or chronic renal failure, and never forget to check for magnesium, because good number of time hypokalemia is associated with hypomagnesemia. So magnesium should be also simultaneously replenished. And this is very important for monitoring. When you are giving an IV potassium, ECG and serum potassium level should be there. One thing is 100% sure, that never give IV bolus of potassium chloride. Never add potassium chloride to isolite M, because already it is containing good amount of potassium. Don't give more than 10 to 20 milliequivalent per hour, and don't give 40 milliequivalent per liter very fast. In a day, not more than 240 milliequivalent in a day. Remember that hypokalemia is safer than hyperkalemia, and over treating can result into hyperkalemia, which is more dangerous than hypokalemia. As far as complication is concerned, person can develop hypokalemic paralysis, cardiac arrhythmias, hypokalemic periodic paralysis, and person can die because of cardiac arrest. And also don't forget, person can develop complication of over treatment and rapid treatment, particularly when it is IV. Among cardiovascular complication, most common is atrial flutter fibrillation and ventricular tachycardia, ventricular fibrillation. And this is more common with congestive heart failure, myocardial infarction, ischemic heart disease, aggressive treatment of hyperglycemia, aggressive treatment in a diabetic ketoacidosis, person on digitalis therapy, person with Conn syndrome, that is hyperaldosteronism, etc. also on methadone therapy. You have to keep a watch. As far as a muscle complication is concerned, severe muscle weakness, flaccid paralysis, and in a severe hypokalemia, person can develop rhabdomyolysis, which can induce myoglobinuria and which can produce AKI. Renal complication, person can develop nephrogenic diabetes insipidus because of acute or chronic hypokalemia. Person can also develop metabolic alkalosis. There can be cystic degeneration in a kidney, and you can have interstitial scarring. These are some of the complications which can later on becomes dangerous one. As far as GI tract is concerned, decreased motility, and because of decreased motility, person can develop constipation and paralytic ileus. In person with cirrhosis, person can develop hepatic encephalopathy. And among metabolic complications, we already mentioned, person can develop some of the metabolic complication in the form of metabolic alkalosis, metabolic acidosis. So I end my lecture here. If you like this particular lecture, please don't forget to press button like, subscribe. You can press bell icon so that you can get a message, and you can share with your friends. This can be asked to you in your oral, can be asked in your theory, and good number of time you will see this group of patients very frequently in your everyday practice, particularly the person who are having chronic vomiting, diarrhea, person who are on diuretic therapies, etc. So thank you for taking out time. I know that your time is valuable, and I appreciate you for spending some of the time with me. See you in next lecture, and your comments are welcome so that I can improve, and all these things is mainly for educative purpose only.